Okay, I think our waiting time is up. I want to thank you so much, our panelists, for this afternoon and our audience. We are very happy to host you in this session of the World Health Summit, regional meeting for Africa taking place here in Kampala and on online platforms. My name is Bruce Chirenga. I'm your co-chair for this session. My co-chair, Dr. Mwebesa, the Director General of Health Services, will be joining us shortly. But I'm happy to report to you that most of our panelists have already arrived in the meeting. We have Dr. Amsalu from University of Addis Ababa, Ethiopia. He's here. We have Dr. Bruce Bykert from University of Cape Town. He's here. We have Dr. Arthur Kwizera from Makerere University. He has arrived in the meeting room. We have Dr. George Nyali from University of Nairobi. He's yet to join the meeting room. Our IT team is supporting to make sure he joins. We have Dr. Rosemary Bianima from Lago Hospital. She's in the room. And Dr. Annette Gavirano, who has also arrived in the meeting room from the Ministry of Health. So colleagues, this session this afternoon is going to focus on a key issue in the response to COVID, providing care to the critically ill. The session will focus on the experiences of these carefully selected panelists from Africa and Uganda to share their experiences. At the end of the session, we'll open a Q&A, and please go into the Q&A, type there your questions. You can even start now. If you came with a question which you think these people will not answer, you can type it there now, straight away. And then we'll have a Q&A session of 30 minutes. Each of the panelists will have 15 minutes to introduce an area of critical care, and then we will all come back and discuss. We hope that at the end of these 2 hours, we will have understood, appreciated the challenge of providing critical care and probably come up with some solutions on those challenges. Without taking much time, I want to invite our first speaker, Professor Amsalu from University of Addis Ababa, a very good friend of mine. We've been working together before COVID, but when COVID came, we repurposed ourselves to our science to COVID. Dr. Amsalu is an academic clinician, as I told you, from the University of Addis Ababa. He's a pulmonologist, and he has been mentoring and researching for over 20 years. His credentials are in our abstract book, which is online. You can download it and look at it. But all I can summarize that Amsalu started the first pulmonary critical care training program. No, it's not the first, but the really the African original pulmonary critical care fellowship in Addis Ababa, and he's very successful. I've been to his program, and I am happy to introduce him to you to tell us how he has repurposed this program to respond to the needs of COVID-19. Dr. Amsalu, you are welcome to make your presentation.
Thank you, Bruce, for your kind introduction, and also I will thank the organizing committee for really giving this opportunity to talk on building capacity for critical care in Africa. So good afternoon, everybody. My talk is just more of general, and then probably the other presenters may kneel down into what are the key points. So without taking much time, I'm going to talk about how to build capacity for critical care in Africa. So this is the outline of my presentation. As you know, the first case of COVID-19 was reported in 14 February 2020 in Egypt. So by this time, more than 5.4 million people are now confirmed to have COVID-19, and then active cases are more than 500,000 this time, and then a total of 4.6 million people are recovered. And then it causes more than 140,000 diseases in Africa, and then almost all part of Africa is involved with COVID-19. So when you see the cumulative confirmed COVID-19 cases per million, so there is a steady increase in Africa as well, but there is rapid increase as in other parts of the world. But in Africa, there is slowly increasing, where we are just what we are now looking is there is a steady increase in number of cases. So in general, COVID-19 pandemic has stressed the health system throughout the world, especially in low and middle income countries. When it comes to critical care, this is really much stress, particularly in Africa, where there is no well-developed critical care services. So not all patients with COVID-19 require critical care services, but generally most literature says that 5% of patients infected with COVID-19 require critical care services. So especially with ARDS, other organ failure, they require critical care services. But generally critical care services really overburdened, and there are a lot of competition for critical care in Africa, also in other parts of the world, because there are a lot of acutely sick patients who demand for critical care. On top of that, when COVID-19 comes, definitely critical care service in Africa is really a major challenge to admit to serve patients because of really lack of critical care services in those places. So generally the basics of critical care for COVID and also non-COVID is one should have to be versed with use of mechanical ventilation, also able to monitor hemodynamics and also identify secondary infection and really provide excellent nursing care, and then also able to apply all ICU bundles and then start hemodialysis if it is required. And then of all, teamwork is very important. So those are the basics we need to implement, and then really to put all those in place is very challenging during COVID-19 because of really increased number of cases and then limited resources. So when you see critical care in Africa, the total population of Africa is more than 1.2 billion now, and then critical care medicine in general is not well developed in this continent. And then when you see a critical care bed, it is less than 1 per 100,000 when compared with the Western population, which is basically 5 to 30 ICU beds per 100,000. So the volume of unplanned admission with COVID-19 adversely affect critical care outcomes in Africa in general. Also, the ability of African healthcare system to adopt and expand during this pandemic meets with the clinical workload has been limited, and we face a big challenge. And also the outcome of critical care patients in Africa is really poorly documented. So the whole issue of ICU requirement is basically monitoring physiologic changes during acute illness. So this needs very expensive equipment and also high quality laboratories and also large number of skilled and trained individuals. But to put all those together in low and middle income countries is very difficult. So this kind of model of ICU or critical care is really impractical in Africa. It requires a lot of resource and also very expensive. To show you some of the examples, for example, this is one of the fancy ICU in Vietnam with highly cubed and with a lot of monitor, infusion pump and so on. So when you see this is a patient admitted to ICU with a lot of lines and then a lot of instrument around, which is very expensive. So for Africa to put this kind of ICU in a very critical time is very challenging. So we should have to really invent something which is possible and also applicable for Africa. So this kind of ICU is really difficult for us to, and then we should have to really develop something which can really help African patients and then save life. So I will start with the challenges before I will go to some of the recommendations. So just what is the challenge in Africa in terms of ICU is really infrastructure. There's a limited ICU services, and also the ICU, which is already developed, is also, they are not equipped with protection for airborne infections like a patient with COVID-19. So there is no negative pressure in those ICUs, and then only very few countries have this kind of facilities. And then a number of beds, the number of ICU facilities we have in general is very limited. So really in this condition, what we do is just really use what we have, and then probably what we use in our circumstances, we ventilate the rooms, and also we really share the rooms for 2-3 patients rather than one patient occupying one room. And then the other is the capacity, also another major challenge we faced during COVID-19. And then during surge, there was imbalance between the available ICU facility and also a number of patients requiring ICU care. So the number of beds were insufficient, the number of ventilators, consumables, and also drugs, particularly essential drugs for COVID-19, particularly antibiotics. The pressures were run of shortage. So really this should have to be carefully planned, and then you should have to plan at least carefully, and then nationally, and then regionally, how many ICU you should have to have, and then you should have to really carefully capacitate those ICUs, and also you should have to fulfill the logistics required for maintenance or management of ICU cases. And then really one should have to also look into the organization of ICU you are going to have. So in our country, we have 3 levels of ICU, primary, secondary, tertiary. So the primary one is basically just resuscitative areas. And then the secondary one is basically gives you some sort of ventilatory support and then hemodynamic support. And the tertiary one is well equipped with all possible ICU facilities at least at a low and middle income country. And then the other important thing one should have to do is SWOT analysis for ICU capacity, infrastructure, equipment, supply, and human resource, so that you identify your primary gaps, and then you should have to try to fill it. And then if you need new ICU, also you should have to establish that ICU as early as possible during this COVID-19. And so you should have to have also regular assessment for quality of care, because during this pandemic, really things are done and in a hurry situation, so quality may be compromised. So that quality should be regularly followed and monitored. So this is one of the study I took, and then this shows how much really ICU beds are really insufficient in many African countries. As surge increases, definitely there is a critical shortage of ICU beds, and then the same is true also for hospital beds in case of COVID-19 pandemic surge. So there are some strategies used to expand ICU bed capacity during COVID-19, like use of non-operational ICU beds, converting one large ICU to accommodate 2 or 3 patients, and then also shifting at least less severe patients to ward, and then admit very critical patients to ICU, and also repurposing some wards like bronchoscopy, endoscopy rooms, and also other areas which are equipped with monitors. You can repurpose that to ICU. Those are what we did in our country. And also repurposing also the ward to ICU is all another action, and also establish the new ICU where there is no ICU. ICU establishment is really another thing. And then also outside hospital, field hospitals constructed, and then in that hospital ICU should be strongly considered and then put into. So the major other challenge is human resources. Staffing is also a major challenge during this COVID-19, and then there is an increased human resource demand, but increasing ICU bed without human resources is really associated with high mortality. So one should have to think when you increase ICU beds.
Excuse me, Professor. Can you kindly increase your volume? The audience wants to hear you.
Okay.
So
Thank you. Thank you. So the other challenge is ICU staffing. So staffing human resource component is really a major challenge. And then, so when you increase ICU bed, concomitantly, one should have to think also human resource. And then without increasing human resource, increasing ICU is critically associated with increased mortality. So one should always think human resource. So shifting human resources from non-ICU to ICU, providing at least short course standard treatment is very, very important. And also always we should have to protect the staff. So there's a risk of staff loss because of illness. This staff may die because of COVID-19. Patient may be, staff may be also medically leave the work because of sickness, and also maybe quarantine because of unprotected exposure. So all those contribute to compromising human resources. So that should be really carefully protected by optimizing infection control and also giving adequate rest for staff, and also communicate very well, and also staff mental health should be also protected. So those are really some of the challenges we had during this time, and then some of the intervention we take is really optimizing infection control, protecting our staff, and also communicating very well, and also discuss what's going on. So really in the long term, as African, short-term trainings are very, very important, but in the long term, really we need also more trained intensivists, PCCM physicians, ICU nurses, and then subspecialty programs to improve ICU care in general in Africa, and then also facilitate transfer of knowledge to non-specialists so that you can repurpose the work to less trained individuals. Otherwise, we may not find well-trained intensivist or PCCM physician everywhere. So just really decentralizing the work is very, very important. But when you do that, you should have to be careful, you should have to train, and then really necessary skills should be acquired by those individuals before they are assigned. So really we should have to also consider including ICU training in our educational curriculums for internal medicine, pediatrics, anesthesia. All those should be really engaged in the critical care management. So just I wanted to share you one of our experience, East African Training Initiative. This is our fellowship program. It's a long-term physician training model in Africa. In this training, we have pediatric and adult pulmonary critical care fellowship program at the College of Health Science at Addis Ababa University, which was started in 2014. This is a 2-year clinical training and also research training, and financed by Vital Strategy from New York, and also Switzerland Foundation from Zurich, Switzerland. And then the collaborative university, primarily we have a lot of collaborators, but primarily Brown University in Colombia. Up to now, more than 15 PCCM specialists have been completed training, and then 6 trainees are on training now. We have international students from Rwanda and one from Tanzania. So the graduates now have played a major leading role in the control of COVID-19 in different parts of the country, and also in advising the Minister of Health in terms of controlling and also establishing ICU, also selection of ICU, fulfilling the requirement of ICU. They are really playing a major role, and they're also involved with expanding ICU service in the region. Really, this team prominently played a major role in the tackle against COVID-19 for critical patients. So the other is always we should have to try. Triaging is really a major issue during COVID-19. We should have to really identify those needy patients, because we have a very scarce resource. So we should have to ration that scarce resource based on the need. So triaging is very important. So to do that, really we should have to have a very good ICU technical working group, which really decide admission discharges, and also we should develop the admission discharge criteria, and also which also develop legal support for ethical consideration sometimes, and also develop guidelines for management of patients with critical COVID. So research is also another major challenge during COVID-19, and the ICU researches are really the same. It happens, the problem of research is the same in ICU, also in NICU. So traditional phase of research are really delayed. We cannot do proper research at this time because of really workload and also a lot of issues. And then also most of the study camps are single-centered and then underpowered. And then most of the research are conducted rapid, and then sharing of research might compromise scientific quality as well. So one should have to really do collaborative researches, and then you should have to be cautious when you interpret any findings. So additional ways to improve critical care in general in Africa, what I really suggest is African countries need more preparation in terms of ICU capacity building, particularly policy guide, and then there should be political commitment for expansion of ICUs in Africa, and also the government of African countries should have to invest on development of infrastructure and also training of human resource, and then capacity building should be really takes place so that we can really prevent this kind of catastrophe in the future, and then really we can manage our patients properly. All stakeholders, including ICU practitioners, hospital administrators, government, policymakers, must work hard to change ICU care in Africa. And then always there is a shortage of resource, but in critical care, we should have to really triage and then also ration then resources carefully. And then the other important point is collaboration and partnership with local, international, regional stakeholders are very, very important in the development of ICU. So my final slide is how COVID-19 pandemic will change the future of critical care. This is a really very interesting slide. So we need more efficient ICU triaging. We need systematic approach to critical care crisis. We should have to really do effective epidemiological registries, and then we should have to do randomized controlled trials, digital transformation, and then expandable ICU staffing pool. We should have to be ready. We don't know when the second epidemic, the second pandemic comes, and also we are still also in the middle of pandemic, so we should have to really ready, and then efficient supply of consumables, devices, and pharmaceuticals. We should have to really manage all those things, and then also better end of life. We should have to prepare ourselves before that, and the more focus on well-being of our staffs, and also restructuring multidisciplinary rounds. So all those are really future direction for COVID-19. In summary, there is a critical need for critical care development in Africa. Even if SARS-CoV-2 infection rate is low in Africa, many thousands will still become critically ill, require ICU service. Collaboration at a regional, local, and also international level is very, very important in generating high-quality evidence research for critical care, evidence-based practice, and then also sharing of data and resources, also maintaining ethical integrity. Thank you very much.
Thank you so much, Dr. Amsalu. Very wonderful presentation. And thank you for those insights on how we should be looking at critical care and ICU in Africa. So the audience, please type questions in the chat. I can see someone has raised a hand, but we will first deal with the questions in the Q&A. Please put your question there. So our next speaker is Professor Bruce Bycott, who is from the University of Cape Town. Because I introduced him, I will just mention one highlight about Bruce. Bruce, at the beginning of this COVID pandemic, quickly mobilized a large consortium of researchers in critical care, and they were able to measure and understand the problem of critical COVID disease in Africa, and published their landmark paper in the Lancet. And this is a very powerful paper, which gives empirical evidence about critical disease in Africa in print. Bruce, you are welcome to make your presentation.
Thanks very much, Bruce. Thanks for this opportunity. Right. Thank you. So it's my pleasure to just discuss the African COVID-19 Critical Care Outcomes Study, or ACOS. So what happened at the beginning of COVID last year is I'm an anesthetist, and we got a research network across Africa called APOR, or the African Perioperative Research Group. And we had been involved in two studies, this collaborative or network across Africa. The one was ASOS Surgical Outcomes, which was 247 hospitals. And then the ASOS-2 trial trying to decrease failure to rescue for surgical patients in 332 hospitals. So we had a well-established network, and we thought we needed to pivot towards COVID because we were extremely worried about COVID and outcomes in Africa. And the motivation for the study was that really we expected the outcomes with COVID-19 to be worse in Africa because we knew we had a limited workforce, and we also had limited intensive care facilities. So we know at the beginning of the pandemic that Europe was running at about 11 beds per 100,000 patients, and we had estimated that in Africa it was running at about 1 bed per 100,000. And ideally, one would want a 1 nurse to 1 patient ratio, but from our surgical studies, we expected that more than 50% of hospitals with critical care facilities had less than 1 nurse per 2 patients. And it was these numbers which really worried us. And so these were the estimates that we had done early in the pandemic on what our resources looked like. So with the knowledge that we expected the outcomes to be worse, we thought it was really important that we establish one, what resources, comorbidities, or interventions may either be associated with mortality or survival in patients in Africa who are admitted to critical care. And we thought if we could rapidly disseminate this information, we might be able to help in how people manage these critically ill patients. And this was the rationale for this study. So how was this done? So this was a prospective observational cohort study of patients who admitted to critical care with suspected or known COVID-19 in Africa. Recruitment was from April to December last year. And basically, we asked all the participating sites to recruit as long as possible, and understanding that if it became impossible because of their service commitments, that they could stop. And what we did was we made an interim analysis available in October last year to inform people of what the findings were looking like so that they could adjust their management if necessary. And the follow-up was in hospital. So really the objectives were to identify critical care resources, comorbidities, and interventions which may be associated with mortality or survival. The primary outcome was in hospital mortality. Secondary outcome were the risk factors associated with mortality. The study was essentially unfunded, so all the sites who participated participated through goodwill, essentially. We had some funding that we secured from the Critical Care Society of Southern Africa, and that funding was to ensure the database and data management necessary to run the trial. These are results. So there's a QR code there you can scan, and that's a full text publication if you want to have a look at it. And if you do download it, I really strongly suggest that you download the supplementary material as well. So this is what it looked like. We asked colleagues in 40 African countries to participate. 26 of the countries said they were willing to participate, and in the end, only 10 countries could participate. I think this is the first really important signal. It tells us how difficult it is in a resource-limited environment to participate in clinical research like this when you have limited resources. But these 10 countries and 64 hospitals provided a lot of useful information for all of us. We recruited 3,100 patients. The mean age was 55, and about 2/3 were male, and the mortality was 48%. So this is the first thing. As part to put our African outcomes in context, we conducted a meta-analysis of all critical care studies that had been published with outcomes. And you see at the bottom there in the red circle that the overall global mortality is about 32%, with a confidence interval of 28 to 35%. So Africa is running significantly higher than the global average at a critical care mortality. And the point estimate for Africa is higher than any other region in the world. So certainly our outcomes are poor. And we estimate of that meta-analysis that for every critical care admission, there's a between 11 and 23 excess deaths per 100 admissions. And that's obviously extremely worrying. So what could be associated with these mortalities? So the first thing is there's a signal of insufficient critical care resources. So if we look at the resources, hematological labs are available on 98% of sites. The ability to provide pulse oximetry to all patients is only available in 86% of sites. And that's obviously extremely worrying if you think this is a critical care environment. Blood gases, about 8 in 10 can do it. Brain ventilation, 7 in 10. Renal replacement, about 70%. And ECMO, only 16%. The next important thing to look at, and this was alluded to in the previous talk as well, is that in the study, nearly 6,800 patients were referred to critical care, but only 3,100 were admitted, 3,800 were admitted. And that means about for every 2 patients who require critical care for COVID-19, only 1 is admitted to critical care. And that's obviously worrying, and we suspect that a large majority of the patients who didn't get into critical care probably did really badly. So what's associated with mortality? So in our patients, increasing age, HIV, diabetes, chronic liver disease, chronic kidney disease, all independently associated with mortality. And then there's a strong signal that severity of organ dysfunction is associated with mortality. So if you have a delay in admission because you've got limited resources, the odds ratio is 2 for mortality. If you look at the quick SOFA score, so increasing respiratory rate, low systolic blood pressure, or lower GCS, they add to the mortality. Increasing respiratory support obviously increases mortality. Patients are rested before admission, and vasopressor requirements. Steroids were shown to be beneficial, so supports the findings from the recovery trial. And if you look at the quick SOFA score on admission, if you got 1 risk factor, so most patients would have an increased respiratory rate, odds ratio is 1.4. If you get 2, then odds ratio is 2, and all 3 quick SOFA variables or factors, that's 3.5. So what we've also done is we've taken the data from the ACOS paper and basically developed the logistic regression model, or made it available. So if you scan this QR code, it'll take you to an interactive risk stratification tool based on all the data. I'm just going to use it to illustrate maybe its utility, especially now during the 3rd wave. So here, this is, I would say, average patient. So you can see we got a patient who's 56. That's the average age of the ACOS cohort. They've got 1 quick SOFA risk factor. That risk factor is almost certainly an increased respiratory rate. They've been referred to ICU because they need ventilation, and there's steroid therapy available. Here we got a probability of mortality of about 39%. So just a bit higher than the global average. Now, if we take the same patient, but now instead this patient has diabetes as well, And instead of just having an increased respiratory rate, let's assume the patient now also has a bit of confusion from the hypoxia. So they got 2 quicksilver points. And because all ICU beds are full, there's a delay in admission. This patient's mortality, predicted mortality, goes up to 70%. And finally, if we take the same patient, and let's say now that that patient is actually HIV positive, and there's no steroid therapy in the critical care unit, the mortality is nearly 90%. So this risk stratification tool, which is basically the data from ACOS, is available through that QR code on the APORG or African Perioperative Research Group website. What are the implications of these findings? So I think there are 2 things, yeah. The first is it's very clear that we got excess mortality in Africa, which is obviously extremely concerning, and it must be driven predominantly by our limited critical care resources. And there are 2 things that for me that become really important, and we need a strategy to improve improve outcomes for severe COVID-19 patients in Africa. And I think we need to think of two strategies: a short-term strategy, so where we find ourselves now, you know, in another wave, and a long-term strategy. So I think a short-term strategy, what we have to do is we have to decrease the number of patients at risk of severe COVID-19. This means vaccine equity has to be the most important principle and drive from all of us at the moment, because we cannot make differences to human resources and critical care facilities now in the short term. In the long term, and this was discussed also in the previous talk, is we need much more regulation of critical care facilities, meaning that we have standards that need to be agreed upon across the continent, that you know, governments are accountable to, that we can ensure that our population has access to adequate critical care resources. Thank you.
Thank you so much, Bruce, for that wonderful presentation. And colleagues, as you see, this is very, very important data about outcomes of people who are critically sick. We know that our country is currently going through a surge, and there have been a lot of people who have lost their lives. So it's important to have these results coming from several countries in Africa, so we can put our problem in perspective. As we agreed, after 2 speakers, we'll allow some questions and clarifications. But before I open you for questions, our panelist, Dr. George Nyali from Nairobi, has managed to join. George, you are welcome.
Thank you very much.
Yes, I hope Nairobi is good.
Well, quite cold, but at least we've seen the sun at lunchtime.
Oh, okay, wonderful. We have too much sun here. So we will go into some clarifications and some questions. I see we have one question in the chat. I'm going to read it. It says, thank you so much for the presentation on ICU. How best shall we have these good strategies and innovations incorporated in the COVID-19 treatment and management? So I think both Amzalu and Bruce, you can go for this question, but probably Amzalu first.
Thank you, Bruce. This is really a nice question. So the issue is we have a very limited resource as Africans, and so you should have to know where to put your new strategies, innovatives. So there are easily implemented innovatives which can be implemented in almost everywhere, like just addition of new beds, and then also just equipping those facilities. But there are high-level technology innovatives and also equipment required to manage critical care patients during COVID-19. So you should have to really know where you should have to going to put those high equipment. So you should have to also have somebody who can going to manage those equipment. So sometimes you may both ventilator, but if there is nobody who going to operate and manage and able to use that ventilator, really this is futile exercise. So really it's better to model where to put those really high level equipment. So that's what we did in our during our preparation. We identify those hospitals who probably serve high level. For example, in Addis, we dedicated 2 hospitals for COVID-19, which is equipped with everything, including dialysis. And then the rest may give also other ICU care. But when the patient require, for example, dialysis and also high-level care, they will be transported, even including surgery in a patient who's probably infected with COVID-19. We can do surgery and also we can optimize infection control. So really the most important thing is mapping and also identify where to put your resources, because the resources are very limited. And then by doing that, you can really save life, and also we can optimize existing equipment materials to be used. And then you can really also benefit the patient, also the society. And then the other is where is a really hot spot where you need those gadgets as well. So if you put equipment which are very important in a place where there is no really high number of cases, there is no need. So you should have to really map. That's what I can say. Thank you.
Thank you, Amsalu. Bruce, any additions?
Yes, thanks, Bruce. I think for me, the real issues are when the resources are so limited. Is one is appropriate triage. So I do think risk stratification at referral is really important. So I do think some of the data from ACOS can help that. The second thing is the use of oxygen to decrease the need for mechanical ventilation. So there's some data suggesting that, high flow oxygenation may decrease patients needing ventilation. That might free up some beds for sicker patients. So again, the importance of linking triage with oxygen, I think, is important. And then clearly the need for steroids for the patients.
Thank you so much. So we have a couple of questions. Let me scan through the urgent ones. We'll come back to others. We have GS from Charité, Berlin. How do you rate the telemedicine as a means to link tertiary hospitals with other hospitals, for example, by having rounds together? I think this is also still open to both of you, so you can go for it.
Thank you, Bruce. Yeah, telemedicine is really one of the tools we highly used in this pandemic, even including outpatient service for refilling of patients, not to really increase the patient load at hospital level. So during COVID-19, we highly utilized at Black Lion Hospital telemedicine efficiently, and then we're just asking a patient distantly and then refill their medication. And also we can also involve it as a consultation. So there is a platform in our country which is organized by Federal Ministry of Health and the regional bureaus. So there are experts already identified, and then those experts are contacted through telephone and still through telemedicine, so that they are consulted and they are engaged directly in a patient care, and then also advice and also in the consultation. We highly use this, particularly for outpatient refilling, so that we really decrease number of congestion and also number of cases coming to for other purposes, so that we can also prevent nosocomial infection related to congestion in the hospital. So we highly use, so this is really very, very important tool. So the future of medicine probably, I will say, is telemedicine is probably one of the components which is probably going to grow. And then in a resource limited country like Africa, where there is only very few intensivists, very few pulmonologists available, I think this is a good way you can really remotely access patients who require the service of all those highly skilled individuals. So really, this is one way I can say. Thank you.
Thank you.
I've got nothing else to add to that comment.
Okay, thank you. I will also add, as chair, one question for each of you. For Amsalu, congratulations on your successful training program for doctors, specialists. Do you have a plan for nurses, for other people needed in the provision of critical care right now? And for Bruce, we would want to tap into your experience. You said you had minimal funding for this consortium. How did you manage to get all these hospitals participate and even go into the best medical journal? I think this experience will be useful to the audience. Thank you. And then after that, we'll go into the second part of this session.
Thank you, Bruce. Yes, yeah, we have already started training of nurses on critical care, which is nurses who have BSc. They will train in critical care for 2 years, which is a skill as well as also deductive lectures. We already developed the curriculum, which is done in 2 hospitals now, Black Lion and then St. Paul Hospital. And then we have that program, and then it's one of the successful program we have. So almost now, most of the ICUs are just run by those nurses, and we have also team from anesthesia and also emergency medicine who train critical care, and then those are the ones who manage now. So we have that program, and then we are successful in that regard. So, but we are now working to also train pulmonary rehab nurses. So that is what we are lacking now to handle particularly the ventilators. So that is the curriculum is now already written, and then we are waiting for approval and to start pulmonary rehab nurses as well. Thank you.
Thank you.
Thank you, Bruce. Thanks for the question. I think what we found is, one is we've got a fantastic network of clinician investigators across the continent. And essentially, these are all people who really want to make a difference and feel empowered that what we're all doing is important. So I think that's the first thing. It's a bunch of clinicians across Africa who feel we together need to work together to make a difference to our patients. The second thing is that we've kept all data points to an absolute minimum. So when we do the research, it's the leanest you can imagine. It's only a few data points. We ask a very specific question, and we only collect data points which allow us to answer that question. We don't collect extra data points because they're interesting. So we keep the workload as light as possible, and we work more on the concept of volume. So volume of hospitals as opposed to volume of patients at a hospital. So try and keep the burden at the sites very low and rather have lots of people collaborating. So lots of small contributions makes a big contribution. And then what's really helped as well is that some of the governments or ministries have got involved. In particular, Ethiopia was amazing in the ACOS study. So their Ministry of Health were supportive and were involved. And I think that also makes a difference, that they showed leadership in the study in Ethiopia. And we've had that with other countries and some of our other studies as well, where ministries of health have also come on board. So I think it's a range of things, but I think the real thing is that everyone who participates feels that they are making an important contribution to improving outcomes for people in Africa. And I think it's that belief which is so important. So thanks for asking the question.
Thank you very much. So we'll now go to our next two speakers. Our next speaker is Dr. Arthur. Dr. Arthur is senior faculty here at the College of Health Sciences at Makerere. He's an anesthesiologist, intensive visit, with a large amount of experience. Most importantly, Arthur was one of the people to start, part of the team which started setting up COVID critical care when the pandemic hit us. He has a vast experience from the ICU itself, but also from academia. Arthur, you are welcome to make your presentation on the experience of setting up a national critical care or ICU system in a low-income country.
Thank you very much for inviting me. Thank you for the very kind words you've mentioned, and I will try to keep this talk brief. When you asked me to talk about this, with respect to what has been said before, we'll focus on what we did as a case study for Uganda, but also maybe other African countries. We can compare notes on how to do this thing. The other thing is obviously making it a focus for with respect to COVID-19. So as it's important to provide a historical perspective to a lot of people who are just seeing the whole concept of critical care in Africa right now. With Uganda, again, the first ICU was set up in Mulago in the early to mid 90s, and it was a gift from the Japanese government. It was a 12-bed unit, and to those that remember it, it had 3 sections. And then there was a British trained anesthetist who was running the unit at the time. Later, Lacho Hospital, which is a private, not-for-profit hospital, and then International Hospital opened their ICUs. Of course, one of the things that we've come to essentially realize, because of the colonial nature of medicine, and also the origin of intensive care, a lot of ICUs are anesthesia-driven services on the basis of the procedures that they performed. So it's a different model. It's what we call a Commonwealth model, and many countries have anesthesiologists as their basic, or physician-trained anesthetists as their basic ICU providers. So understanding that is also important, and I'm happy that there is an emergence of pulmonary critical care who bring an extra dimension to intensive care as a specialty. So at this time, as you can see, even then, physician anesthetists were a big problem, and were one of the principal reasons why intensive critical care capacity in low-income countries was also low. Because intensive care is not just about equipment, it's about the human resource, and we are increasingly seeing this. We then saw the first reports of intensive care in the developing world. Right away, missionary anesthetists with Mr. Jara set up the first, actually public ICU, so to speak, using a Gloucester ventilator, and a lot of their work focused on snake bites and tenderness patients. They shared their work. In 2012, we then set out to enumerate our ICU capacity. At this time, we were not focused on functionality. We're just focused on beds and just breaking down everything. As you can see, obviously, we had about still 1 million, 1 bed for 1 million people. Later, maybe about 7 years later, 2019, we repeated this thing now with a view to seeing how many are actually functional, because it's not just a matter of having beds or equipment. And at that time, we had 12 functional ICU intensive care units. Again, even if there were some strides made, the number of beds per million did not really improve, obviously, because we had an increasing, growing population. So we've done quite a bit of work in trying to improve these things qualitatively and quantitatively. So, we have 12, we had 12, as of 2019, we had 12 functional ICUs. We had renovated, the Mulago National Referral had renovated on the hill, actually, a total of 60 beds. This is in terms of equipment. And there was also a 10-bed dedicated pediatric ICU. We had also redone the anesthesia curriculum in the understanding that we had challenges in terms of skill set for intensive care. We increased the curriculum, the critical care aspect to a full 1 year, so that someone did not necessarily have to go and do a fellowship elsewhere. They could still run a general mixed bed ICU in the country. And of course, we have had a lot of growth in the area of the BSN, where we've actually embedded some critical care aspects to improve their versatility, and also for the country, knowing very well that we'll not have enough anesthesiologists for that matter, or fellowship trained intensivists. We also have, under the leadership of Dr. Bruce, a pulmonary critical care curriculum that was under review, and I think might be starting soon. And we improved our capacities to independently perform procedures like CRT, liver dialysis, TEs, bronchoscopies, and now ECMO, although those would reach maybe less than 1% of the critically ill population. With regards to COVID-19, what did we have? At the start, when case management began in March last year, we understood that the challenges we had as a country. We're lucky that the Mulago Hospital ICU the renovation had just completed or almost completed, and then started surge preparation with some modeling assumptions from the scientists. And the national referral pathway is such that we had regional referral, district to regional, then to the national referral hospital, and we just piggybanked our care on that. But we also use this as an opportunity to say, you know what, now we have this opportunity, let us improve our intensive care capacity, not just for COVID, but for things like maternal child health, HIV, TB, trauma, emergency medicine, and other area NCDs, which are an emerging problem, so that we can actually prevent premature deaths in these conditions. Then we also then did the care capacity planning, which was led by the Ministry of Health. And these were the teams that were put together. We did that again last year, determined the level of care that we wanted to provide at the regional referral hospitals against the available HR, what we can teach quickly. We determined the ICU bed capacity at every health sub-district. We said, let's start with 10 ICU beds per health sub-district, as well as doing an equipment quantification and specification, so to make it easier for that could also be supported by biomedical engineering, as you know that's a problem in our setting. And then we also quantified how much oxygen we would need for both COVID and non-COVID. If I have time, I'll come to that. And then, of course, we did human resource quantification and specifications and did training needs, which we provided to the Human Resource Division of the Ministry of Health. So equipment was procured in 2 phases. This is the first phase. As you can see, we did some trainings. We actually set up this, I think, is Mbale Hospital, Regional Referral Hospital. This was a gunshot victim who was the first recipient of intensive care, ventilated intensive care in Mbale. And then we did things, as you can see, there was quite a bit of training that was carried out by the Association of Anesthesiologists of Uganda. And the initial training was just to help end users understand the basics of this equipment so that it doesn't get destroyed, or in the unlikely event that, or in the likely event that there is a patient, they would have a place to start. I'm happy to say this equipment is still there. It hasn't been destroyed. So of course, some people have been asking about oxygen. We also sought to determine oxygen capacity in this in our setting. and we did oxygen quantification. I'll just run through this very quickly. We also looked at helping people determine, and get an understanding of what is in oxygen, what oxygen therapy entails, how you determine your oxygen capacity at your facility. And also, of course, we did site visits. So all the regional referral hospitals where we had the existing oxygen plants, and then used this matrix to sort of understand how much oxygen every patient is going to consume per day. And then we provided illness severity scores. In addition, we also created scenarios. So we created 2 scenarios: a situation where you had, by level of patient, scenario 1, you had 30 beds in the CTUs that as we call them. How many were level 1, level 2, level 3? That means in scenario 1, you had some non-COVID patients requiring oxygen, either they're in operating theater or they presented with just non-COVID pneumonia or maternal patients or childhood pneumonias. And then we also had those patients that we saw what they required. Then we saw, we had no patients who needed high flow, no patients who needed mechanical ventilation, and we quantified how much oxygen they needed. The second scenario obviously had more sicker patients, and is a reflection, I think, of what we are going through right now. So we did this planning, and this was adopted by the Health Infrastructure Division. I did not mention that we also did planning for the ICU buildings in terms of floor space according to international recommendations. So all this planning that we did helped us sort of build capacity. But I must admit that we're really, really way behind in terms of meeting these things, and it was a worry whether we would meet these targets. So what the challenges? At that time, we had a global supply chain during the pandemic. Now, we just to understand this, it was so hard. I remember the Ministry of Health could not identify, and yet they were probably one of the first countries, could not identify an entity that could supply mechanical ventilators, for example, in that time period. So we were indeed lucky when the first bunch of ventilators came in quite early. Many other things were a problem. Many of you remember PPE and so on were difficult to find. Then funding, of course, was a challenge. I as a technical person, that was also a big problem. And then there was also a lead lag time for training. When you have human resource capacity that has very little knowledge about critical care, you cannot train them in 2, 3, 4 months to gain adequate knowledge that can make a difference in life-saving. You need at least 2 years for nursing. You need at least maybe 3 years 2 to 3 years for physicians, whether no matter whether it's anesthesiologists or non-anesthesiologists. The other challenge is because we're very few was burnout, and many people here I know have suffered this. So because we're the same people doing the planning, we're also the same people providing clinical care, we're the same people doing research and so on. And of course, bureaucratic bottlenecks. This we know, and yet everything was in emergency mode. Many people have experienced this in many parts of Africa, and I suppose even high-income countries. Teething pains of critical care. Critical care is new to a lot of people. And so understanding that it's a very expensive venture, understanding that it's better to prevent, and I like that this has been discussed before, that prevention is better than cure. The cost of intensive care are now a very serious issue in Uganda. It's been quite topical, but there's no way you can run away from it. It is very expensive because it's more or less the tail end of medicine. So with some of these things, they say you have a PhD in hindsight. You learn as you go along, and there has been a lot of criticism, but these are the teething pains of intensive care. Lessons learned, there are more waves coming, because as we know, vaccines are not going to be adequate, and we need to continue to learn from the mistakes that we've had and improve and keep planning with every wave. The other thing is implementation. It's one thing to plan, it's another thing to implement. And this pandemic has also taught us that having things on paper does not equate when the time matters. So implementation science is another area that we need to focus on, the whys of things, why are things not happening when they do not happen. Having said that, I want to thank you, World Health Summit, for inviting me, and please stay safe. Thank you very much.
Thank you very much, Arthur. That was wonderful. The perspective and the history is very, very critical. We'll get back to you with comments at the appropriate time. So colleagues, allow me quickly introduce our next speaker. Also recognizing that probably I have not managed the time very well, but I think I'll be fine. So our next speaker is Dr. George Nyali from University of Nairobi. He's a pulmonologist, and we have worked together several projects. I have also to mention that Dr. George Nyali, like all pulmonologists and intensivists, had to repurpose himself for COVID care when the outbreak came. We would want to hear the experience of Nairobi. Do you know why? Because a couple of times when our patients here do not do well and we need an extra hand, we bring them to Nairobi. So we want to hear this Nairobi thing, George, that you have, that you give additionally, so we can start giving it here. George, you are welcome to make your presentation.
Hello. Hello. Looks like my internet is unstable. Hello.
Yes,
Am I
we can
audible?
hear you. Yes, we can hear you
Oh,
now.
okay. Sorry, internet has been a bit unstable. So I'm going to talk a little about critical care treatment of COVID-19 and our experiences in Nairobi. And I'll tell you a few things. And then I'll try and balance it out with what resources we have. That's just my disclaimer, nothing much. I'm sure everyone is aware that we have an early stage when it's replicative. Most people look okay. Then later on, you go to the later stage where people get very sick. And at that time, the virus is not as active, but they have a lot of inflammation. And these are the people I'm going to talk about. So I'm really going to focus on the second stage of disease, which is the severe disease that comes later on. And we've talked about it before, is that the best way is to prevent people from getting to severe. So it means at the earliest opportunity, we must triage our patient to know if they are COVID-19, who are those at high risk of becoming severe and those who are not severe. And we know this from last year, from China and the data from Europe, that anybody over 60 with comorbidities is at higher risk. And even in 60, they don't have comorbidities, but they have high risk labs, which includes leukopenia, high white cell counts, and a high neutrophil lymphocyte ratio, then they are at risk of developing severe disease. And not to mention the percentage of the high resolution chest CT scan that basically has been involved in the disease. Now, the question is, what can we use to prevent people from becoming, moving on from mild disease to becoming severe disease? And remdesivir. Remdesivir is really an antiviral. At the starting of this pandemic, we had both favipiravir and remdesivir, but remdesivir has over the time proved to be superior to favipiravir in terms of getting people to reduce their viral loads earlier. So in those people who come early on, they have high risk factors, leukopenia, they're running high fevers, we do still give them remdesivir. It's good to mention that this must be early on, because once the virus has taken a hold of the patient, giving it later might not be useful and you might not see any benefit. The other drug is ivermectin. I know this has been controversial, initially started by the Australians, and then the Israelis followed suit with their Sheba trial. which showed that people who got ivermectin, if they had ceased to shed virus earlier, more important in public health, preventing infection and passing on the infection. But I think if people stop passing the virus earlier, probably they might not progress. Data is still low. We probably need to look at this and see in patients who have classified as high risk, how many do we prevent from going to ventilation or requiring critical care support. Vitamins, this I'm sure everyone is doing it, even in Uganda. There are quite a lot of concoctions that have come up, and people have come up with what we call dawa here, which includes a lot of orange, there's ginger in it, and mint, and also people have now started taking actually vitamin capsule. The issue is data is still low, doesn't show quite a lot. The best study we have is still the Citrus Alley study, which was really in critical care patients, where it showed people came out early of ventilation, but it preventing people from progressing, that are still missing. Zinc sulfate is another drug that has been used, actually initially used with hydroxychloroquine, and people started seeing that if people were given zinc sulfate, they tended to do better, and people thought it potentiated the hydroxychloroquine. But later on, zinc on its own was shown to have an effect in reducing infection of new cells. And the question is, if it's given early, and probably at adequate dose, which people would struggle, is it 20, is it 40 milligrams once a day? Would it stop people from becoming? And I think these are some of the things that we can actually study here in Africa. Inhaled corticosteroid, this has been shown to prevent people from moving from just needing supplemental oxygen to requiring ventilation. The first study was obviously the Stoich study, but now we've had other study, including the one of Symbicort in HESCO. There's one for, there are quite a number of other inhaled corticosteroids that are currently being studied. But we know this works through anti-inflammation, and it's important that when we see patients early on, especially when they're coughing and getting episodes and complaining of breathlessness, even if they're not wheezing, then you can try a bit of the budesonide inhaler, or the Symbicort if they have wheezing as well. Monoclonal antibodies, we've started using this in Nairobi, but they're quite expensive. And the answer is if we use them earlier, probably would it give us a better. The issue I haven't seen about it is about the cost-benefit analysis. And they tend to be quite expensive and out of reach for most people. Now, when we're talking about people getting worse and we're escalating care, okay, we always try and categorize patients in critical care into easy groups to be able to follow. Green are people who really have good respiratory, they're getting the oxygen well, and all what you need to do is monitor and observe. In yellow zone, these are people who are starting to get tachypneic, and actually their saturations of oxygen are actually starting to drop, okay? In the red zone, there are people who are very tachypneic, needing very high oxygen flow, and these probably need to be given oxygen with a certain pressure, or a PEEP or CPAP to be able to be ventilated, or actually do invasive ventilation. Now, I've taken you to this old document about non-invasive ventilation, because non-invasive ventilation is a lot cheaper if you do it well early and you support and you give adequate oxygen. You'll decrease a lot of people going into needing mechanical ventilation, because we notice that the first thing when people miss oxygen is that they get confused. And once they get confused, then they can't control their airway and you will be forced to intubate them, okay? So you need to recognize early patients who are actually needing additional oxygen, okay? And try to put them as early as possible on either CPAP or BiPAP, depending if they have only type 1 or if they have type 2 respiratory failure, put them on BiPAP so that you can forestall need for intubation. But I should say you should not delay intubation should it be required, okay? Now, here we have quite a number of devices. We have the high flow nasal cannulas, which we've used here in Nairobi with quite a good outcome in quite a number of patients. Usually when you give it, the air is warmed, people feel comfortable and it's quite moist so they don't get very dehydrated. And since we can go all the way up to 60 liters per minute, then we are able to give them adequate oxygen, and quite a number might not progress to needing either NIV or ventilation. Now, before I talk about CPAP, I need just to show, oh, okay, the slide has disappeared. There's a slide on how high flow nasal cannula oxygen should be given, but I'm sure most people know this. If you're not getting adequate oxygenation, okay, and basically you're monitoring them every half an hour to 1 hour to see how much they need, then here we usually put them on either NIV by mask or by hood. We've pioneered quite a bit of using helmet or hood ventilation in Kenya, where we put a hood around your head and we are able to give a PEEP. Best low, but we've tried 12 and 14. Once you get to 14, there's a bit of leak and it doesn't give you very good hold. Now, a bit of recommendation on the ventilation. This is from the international guideline that anybody less than 92 can be started, but you must give it less than 90, you must give supplemental oxygen. If you're having oxygen still going down, and that has been the question, should we always do arterial blood gases to be able to decide on this? But actually we know if you just use the pulse oximeter and you find that despite increasing your oxygen, they're not getting to 85%, probably you can graduate them to either high flow nasal cannula or NIV, depending on what is available to you, or a hood. And if you have an NIV, basically a patient has to be awake, able to control his ventilation. I'm not going to go through all the recommendations because this is something you can be able to read, but you must make sure they're alert, they're getting adequate ventilation, they're not getting dehydrated, and that you're getting good oxygenation. If you require a PEEP more than 10, then you have to start strongly considering moving to invasive ventilation. And if you're above 14, probably you have no option other than to go to invasive ventilation. The biggest trouble has been, is it just a pneumonia or is it the RDS that makes people get worse? In my opinion, it has been very difficult to differentiate the two because the COVID pneumonia actually is a pneumonia but does result into ARDS. And whether it's important to differentiate the two, probably to me, it's not as important. All what you need to see is how well are these people ventilating? Is the chest going on? Are you getting new infiltrates on chest X-ray? Is your PF ratio going down? And if it's going down less than 100, then you have no option other than to mechanically ventilate them. Once they're below 300, we consider it. But what we notice that when you have a lot of numbers, you have a lot of people who, if you do a PF ratio less than 300, you'll get quite a lot that will overwhelm you. So we tend to actually only intubate those who are below 100, if the PF ratio is less than 100. And you see as the RDS gets severe, obviously the mortality gets worse. Now, NIV, initially we didn't use it, but we started using it once fear dissipated. And there were quite a lot of studies, mainly from the Middle East coronavirus, that showed NIV didn't work well and there was higher mortality. But on the other hand, the Chinese said they used it and it had given them good results and it was their first line. So on basis of this is why we started using it. And currently quite a lot of people are getting NIV. It's cheaper, it's easier, and it will help quite a lot about, I would say, the people, because about 90% will not need critical care. But that 10% that needs critical care, about 60% will be able to be handled just by NIV or by hood ventilation. Now, what we always do, this is part of the logarithm we use, where when somebody comes, you said, are they hypoxemic? Are they a direct indication for endotracheal intubation? That means that they severely hypoxemic with a PF ratio less than 100. Are they unconscious? Okay. If there are indications, then we directly go to intubation. If not, we start looking at supplemental oxygen, and right from giving oxygen by mask and by non-rebreather mask, and we try and see, are they tolerating it? Are they getting good saturations? Really, we target oxygen saturations above 90. If you're below 85, we want to take you up. If you're not getting adequate, then we either go to high flow nasal cannula. If it's not comfortable for you, then we do put a hood ventilation, which is helmet ventilation for us. These are high flow nasal cannulas. Now we have got quite a lot of them from China, and they've become actually cheaper, so we use quite a bit, and it delivers good humidified oxygen at a good temperature, and it also gives us a little bit of PEEP, especially if you get to about 40, you have a good PEEP of about 4 or 5 centimeters of water. The issue is that most people do open their mouths, so we think we don't get adequate PEEP when people open their mouth. So the advantage is that it gives you heated humidified oxygen. You can increase to meet the ventilatory demands. It does give a functional residual capacity via the PEEP. It's lighter and easier than CPAP. People don't feel really tight, and there's no claustrophobia. And you can wash out dead space because you're actually giving quite a high rate. What we've really tried to pioneer is this helmet ventilation. So as a society in Kenya, the Respiratory Society in Kenya, we did go out early in the pandemic after the first wave, where we sourced this from America, and we've actually had 2 suppliers, and we actually supplied to the hospitals in and around Kenya, and we've trained people to be able to use helmet ventilation. The good bit about helmet ventilation is that it's easy to use, and we are pioneering it to see if we can just use it with an oxygen concentrator as opposed to using it with a ventilator, because that would be a cost saving, especially in Africa where resources are limited. So the trouble is that once you go to a PEEP of 14 and above, there's a bit of a leak, especially around the rubber around the neck. So usually we can't be able to get that. Now, I'm sure intubation, this has been talked about, and the indications are there. If somebody has already collapsed, has had CPR, he's not able to control the airway because he's unconscious, or he's very tachypnic, and you really can't get him to do any synchrony, or severely hypoxemic, as I've talked about. These we intubate early requirements and to prevent yourself from getting infection. These are recommendations. You can be able to read them off any book. And what we basically do, the steps, oxygenation, getting people ready, how you're going to monitor and how you're going to intubate. And this also, Kuzera talked about it. And basically how you're going to monitor them. What are the targets that you're going to look at? What I want to talk about is basically the other therapies that you need to use, and I've just put them in this. And basically all our patients, we do give steroids. Dexamethasone is the most commonly used, but all steroids actually work. If you don't have dexamethasone, or if it's more expensive, you can be able to use your prednisone as well as it's adequately dosed. And we've used prednisone in some places where dexamethasone was not available. And it has actually given us good outcomes. Obviously, oxygen needs to be there. Remdesivir early on, as I said, later on, not much. I've left out the monoclonal antibodies because they are really expensive and not a good option in our resource-limited settings. Now, things that you'll have to face is whether patients are just in shock or they're having a cytokine storm. Well, difficult to tell because both of them do give hypotension, but either way, we say they're in shock because in that shock state, then they'll not be able to get enough oxygen. And it can be because of the cytokine release that forces them into this kind of state. We always give them fluids to try and get adequate, and we start vasopressor early. And usually our choice vasopressor is norepinephrine. If you don't have norepinephrine, then you can use dopamine. That's the other thing that you can use. Try to use balanced fluids, and usually we use a restrictive kind of fluid regime, usually about 4 mL per kilo for the resuscitation phase. We try and try to get a central line early to be able to monitor their CVPs, and sometimes we do loops to be able to see if they are adequately looking at the pulse wave contour analysis. So those, I think, are part of the recommendations that I'll give about mechanical ventilation and about using non-invasive. The other things about drugs, I'm sure most of you know, and I shall not talk much about it. And basically, I'll ask maybe what way can we do? We know critical care is expensive. We must judicially use the little money. And if we can prevent that 10% of people with severe disease from needing mechanical ventilation, then I think that would be our best option. Thank you very much, Bruce. Back to you, Bruce.
Thank you very much, George, for a wonderful presentation and bring out key aspects of treating COVID-19. I want to remind our audience on Zoom, you can type your question in the Q&A. I see there are some questions. But also I want to inform our panel that this session is being broadcast live on national TV. I want to thank the management of UBC for accepting to stream this session. The reason we did this is because we are in the middle of a surge and there are many people who are participating in the care of COVID-19 patients in different ways. Even if you are not a medical person, you could have someone who is sick, could have someone at home. But I want to apologize. Some parts are a bit complicated for the non-doctor audience, but do not worry. In teaching, we have something called theory of knowledge, which talks about memory hooks. Some of these words look strange because you are hearing them for the first time. But next time you hear them, they will be more familiar than they are sounding today. But we thank you for following the meeting. Our next speaker is Dr. Rosemary Byanyima, who is a senior consultant radiologist, but is also the deputy director of Mulago Hospital, mainly involved in organizing care for the hundreds of patients who we treat here at the Mulago Corona Treatment Unit. Because of that, we have requested her to talk about how to organize resources to provide care. As the nurses, these intensivists and doctors we are seeing as they go on doing their work, someone must organize them to be able to provide care. Dr. Byanyima, you are welcome to make your presentation.
Thank you very much. Bruce, can you see my screen?
Yes, we can.
Yes, allocation of resources is the most difficult, especially in developing countries. I'm Rosemary Byanyima, the Deputy Executive Director of Mulago National Referral Hospital. And that picture you see in the corner, in the extreme corner is where we admit our COVID-19 patients. And once in a while, you see news headlines, Mulago choking on patient numbers due to COVID-19. I structured my presentation along the WHO health systems building blocks. so that I can cover the key areas in health systems. But as a way of introduction, Mulago National Referral Hospital has the Upper Mulago and Lower Mulago. Lower Mulago is 900 bed capacity. It has been newly renovated using African Development Bank loan and remodeled. And as part of remodeling, we have piped oxygen to all the beds in the hospital. And also we have an installed vacuum and medical gases, though pending completion. So with such a capacity, all our beds can be easily converted into HDU. But we also have 27-bed adult ICU, and as well as 15 pediatric ICU beds. Currently, it's the 27-bed ICU that we are using for COVID treatment. Remember, the renovations of this Lower Mulago was not yet complete, so functionalizing the entire setup is still a challenge in some areas. As of yesterday, Mulago National Referral Hospital had admitted a total of 3,953 COVID-19 patients, and we had 168 in our wards, 15 of whom are in ICU and 153 in HDU. In the last 1 month or so, our admissions have risen from 10 to 20, and at times we admit up to 40 patients a day. Okay, now using the pillars in healthcare systems, looking at leadership and governance. As Mulago National Referral Hospital, we still use the same leadership structures in taking care of the COVID treatment unit. But as a hospital, we set up a task force to prepare the hospital for this task. And later on, when we started case management, we chose a physician to head the unit, and then also put in place an area manager, nurse, and also selected ward in charges to oversee the setting up and running of the different wards. On a daily, every morning, we have a meeting to recap and get reports from all the wards in the COVID treatment unit. And this has been very helpful so that we are on top of things to know what is happening. Infection prevention and control is a top priority. And we have lucky that we received support. We continue to receive support from all the institutions on the Hill. Mulago Hill has several institutions. But this is not without challenges because as the top management, we are really engrossed into the day-to-day management of the unit, and wish we had an oversight structure that would support resource mobilization. So it stretches us to do both. We also do not have like a primary healthcare arm, although would really wish to follow up like our patients and also reach out to our surrounding communities so that they benefit from our expertise, but we are unable to do that. So the other pillar of health financing, as a hospital, of course, we worked within our hospital budget, and that shows you how stretched we are. Of course, we didn't expect such expenditures arising from the COVID pandemic. But we've worked closely with the Ministry of Health to cover some of our costs because of increase in waste management, the cleaning, the catering for the patients, name it. And the Ministry of Health has picked some of these costs, as well as paying a token of allowance to the health workers. But Mulago continues to take care of the welfare of the staff. And also from time to time, we also chip in for the welfare of the patients. That table shows the number of staff who are within the unit. You can see it calls upon a very wide human resource cadre mix to be able to run the unit. So in terms of the other pillar, which is medicines, vaccines, and technologies, as Mulago National Referral Hospital, we get our supplies from the national medical stores by making orders according to our procurement plan. But we have also benefited from donations from WHO and many other organizations. As you can see, our team of nurses was here receiving some protective gear from some of the donors, and we are grateful. We've really had a lot of organizations coming in. We had a new oxygen plant installed, and in the first wave, we did well because we did not overshoot the plant capacity. But in this second wave, we have overshot the plant capacity, and that has led to some challenges. So we had also to come into use oxygen concentrators and oxygen cylinders. But of course, when we are taking care of critically and severely ill as a national referral, that is the category we take care of, it is quite challenging using those two. It is easier when you are using piped oxygen. Personal protective gear and the IPC materials at times are a challenge, and we have to really ration, and that compromises on care. We understand, of course, it's a global challenge, but of course we talk for ourselves. I mentioned that when we have oxygen challenges, we have refills from some of these companies like Steel and Tubes, Refillings. UPDF also has a plant in Nakasongola, and Oxygas. Those are the places where I've had to do refills off station, and that means transporting these cylinders and then transporting them back, and you depend on these people who are really doing for you the donation, whether they are able to refill in time. So this has led to sometimes stockouts of critical drugs, because when you order, hoping that the numbers will be maybe 20 admissions and they spike to 40, then you find you are running short on sometimes. And when you have to, like, again prepare for admitting more patients, and of course the ambulance system is hard pressed to deliver patients, and you are telling them, hold on, then the message goes out that Mulago is full, they cannot admit, yet you need time again to prepare for a bigger number of patients. And at times we run out of the oxygen administration accessories like the flow meters and others, and it needs time also to set them up, test them before you can safely admit patients. This really has exhausted the hospital budget, and but thank God we are able to work with other institutions, even other sister government institutions. We ask them to procure on their budget for from the national medical stores, and then they transfer those drugs and consumables to us. All our equipments are in high use, so they break down, and maintenance is also coming up as another high cost of care. In terms of health information, we are really using rudimentary systems, like we have a help desk where we have social workers and the psychosocial nurses who attend to the patient's relatives, and also going to visit and talk to the patients inside when they are donned. But we use telephones to communicate between the wards, and this is really kind of rudimentary, but in the renovations, if it were complete, we have the component of the the information health management system. And if this was already fully installed, then it has also a component of telemedicine. Would be able to do video conferencing from inside and outside the wards, so that if someone is inside reviewing a patient, can consult the person without, and also entering the patient information onto the system, can still access the information when it's out. So unfortunately, this system was not yet fully installed and we cannot utilize it. It would have been nice also to use other IT staff for logistics management, so that we can quickly detect like stock outs, and also functionalizing the nursing stations, because that would ease patient monitoring. Then patients want to talk to their loved ones. Of course, if we had these technologies, then patients can talk to their relatives if they are not too ill to speak. It's very psychologically satisfying when they do talk to their loved ones. Now, in terms of workforce, I've already shared the numbers. We know, of course, the international standards, but we are really not quite meeting the standards. On average, in our ICU, it is 1 nurse to 2 patients, because if you have maybe like 12 patients in there and you have 6 nurses, you have to have a 7th nurse who is in circulation in case the people inside need anything. So we're not doing so well on that, but we are grateful that Ministry of Health fast-tracked recruitment. But remember, they are recruiting people who they wish to work in CTU, but they have not yet attained that special training, and that is very critical. And on-job training, when there's a lot of work, is quite a challenge. And when the first upsurge went down, we started sending our nurses for this critical care nursing training. But then the second wave came before 30 of them could complete their training, and we had to recall them. And you can imagine the disruption in their training, but they had some skill, and the on-job training, they are doing some work. So our shifts in ICU are 4 hourly. The HDU, it is 6 to 8 hours, depending on how heavy the ward. And we tend to segregate those who are HDU and are more critically ill. We put them together in what we call a red zone, and that helps us to pay more attention. But definitely not ignoring the others, because by the time the patients require that HDU care, although their severity may vary, still all of them need that attention. So we still have a challenge of shortage of well-trained and experienced ICU staff. We get high mortalities. I was seeing the statistics from those presentations, and this is quite traumatic to the staff. We've had to bring in the psychiatry team for psychosocial support, not only to the patients and the attendants, but also to our staff. So we offer them that service. And some of our staff in the CTU contracted the COVID-19 infection. But fortunately, as Mulago National Referral Hospital, we have not lost the staff to COVID-19. So the other pillar I looked at is health service delivery. Yes, we are happy with the infrastructure or the renovated Lower Mulago, although it's not 100% complete. In the same project, we had a component of ISO certification and accreditation. So we had done extensive work in that respect. So it was a good priming for our people. So when we're telling them develop clinical protocols, SOPs, it was not something new to them. So the staff quickly adopted into doing that. But we've also worked very well with the referral system, being that we receive severe to critical patients. the emergency medical services and the ambulance system has been helpful, but occasionally you have patients who are brought in by private ambulances without prior notice, and they are bringing a critically ill patients when you're ill-prepared to kind of quickly evacuate this patient to a prepared bed. So that also poses a challenge. But by and large, Mulago has worked well with this ambulance system, but we need to again really streamline the referral system so that patients can be received quickly and in a timely manner, because it's critical. And also the ambulance service needs to take good care of patients as they evacuate them. Of course, from time to time, the CTU gets overwhelmed, and that is expected. Of course, this is a pandemic, but our staff are doing their best. They are, of course, they get a bit of burnt out, but we are grateful for the work they do put in. Well, other factors really which we've been grappling with is the coordination with the other players in COVID management. We have to work with different teams. There's very good political will to support the CTU, and we've gotten a hearing here from the political platform. The communities, clients, relatives, cooperatives, some of them, of course, are desperate and are quite demanding, but we appreciate when they are quite apprehensive when they have very ill patients who are in isolation. So there's need for much more resources in all aspects of health care delivery in order that we can be able to offer better services in this pandemic. It's a pleasure for me to be able to deliver this note on the World Health Summit, and I thank you for listening.
Thank you very much for that experience from the front line of managing a hospital for COVID. We will move on to our last speaker, but definitely not the least, and that is Dr. Annette Alenyo Ngabirano, who is an emergency medicine physician. But most importantly, she's the person who has been managing the movement of patients, COVID patients across Kampala and the country. Recently, I overheard her saying that because of the too many calls of people wanting to be evacuated, her phone expired. And I'm not fundraising for her for a new phone, but just so you know. So Annette, please welcome to make your presentation. We are almost running out of time, but we are still good. Thank you.
Thank you very much, Dr. Chris. I definitely do welcome a new phone. Thank you. So I'm just going to give an overview of emergency medical services and their role in supporting the COVID pandemic, but also parallel continuation of essential services. Dr. Byanyima has gone through this, building blocks for a health system. And so I won't focus on the building blocks. I'll just point out the key issues, the key blocks that we focused on in trying to strengthen our emergency medical services. And that is human resources and training, infrastructure and equipment, and that includes medications, data management, processes and protocols, and finally, leadership and governance. I appreciate that this is a stream based on critical care, but just like to remind all of us that patients do not magically teleport from their homes or from a small facility into the ICU. Before patients get into the ICU, they go through the health system. And what they go through is part of the emergency medical services or emergency care system specifically, which stretches from pre-hospital, and that includes scene care, care during transportation, and care in the facilities, specifically the receiving units in a facility, the emergency department. And all this is well captured in the WHO emergency care systems framework. So I'm going to relate the entire continent to what we've seen with Uganda over the past slightly over a year, but also give a few comparisons here and there to lessons we've learned during the first wave and also the second wave. So when we were hit by COVID on 21st March last year, the emergency medical services system, a lot of it was in documents. A policy was being structured that was in process of being presented to the cabinet. A strategy was in final stages of being approved. As far as training, Makerere University had its final year students, pioneer students, emergency physicians. Makerere had its students in second year. A little pockets of research in emergency care here and there, a few protocols, most of them are related to the two training institutions, that is Makerere and Mbarara. And we had bits and pieces of private providers providing pre-hospital services, the city ambulances and other private ambulance providers, facilities having ambulances. We had our members of parliament and other good donors giving us ambulances, but without clear protocols and processes that they must use to safely manage patients before they reach a facility. So that is the landscape we inherited with the first wave. And it quickly became obvious to us that unless we focused on principles of provision of standard emergency care, we were completely going to be annihilated by the first wave. And so we quickly worked on creating a team. And I can say that the initial pillars of care for example, the case management team, initially there was no EMS. It literally required a lot of advocacy for an emergency medical services sub-pillar to be created. And it quickly became one of the core pillars that actually sat at the middle of coordinating all the other pillars. And that is because we interacted with patients, we interacted with facilities, we interacted with relatives, friends, and were at the core of a lot of processes that had to be done right so that we have an established functional continuum of care so that patients are well managed on scene. And I'll start with the scene care. So our scene care initially was not, it barely existed. A lot of it was trauma heavy, but there was no proper guidance on what a COVID suspect or a confirmed case should be managed on scene. We had stories of people being picked from home without properly being managed. And by the time they got to a facility, they are actually dying. And so we quickly worked on our protocols and guidance, and we do have pre-hospital emergency care guidelines for COVID. It's a booklet that goes through the entire continuum. So the scene care, we made recommendations, professionalism, of ensuring when someone is a suspect, a system is immediately activated to take over coordination of this patient. And on scene, we were called by families, by the police, a lot of this in the first wave, because the first wave was very kind to us. A lot of the patients we were seeing were either asymptomatic or mildly symptomatic. We started seeing severe and critical cases around 4 or 5 months down the first wave. And so in the beginning, a lot of it was containment. So police, truck drivers, those are the types of interactions we were having initially. And so we had protocols that ensured that a patient is, for example, if they are suspect, should be at least 2 meters away from the people who are, from a crowd or anyone around them. They should be kept calm. If they're not if they are in any distress, they should be encouraged to sit upright, to calm down, a few things that improved the situation as it was at Scene Care. We also encouraged families that were calling in to, gather drugs and any other type of medications, etc., that patients routinely took as part of underlying chronic conditions. As far as the system and activating a coordination system, so in the first wave, we had multiple pockets of coordination that helped us initially because we were not seeing very sick patients. We got to a point, however, where we did a lot of utilization of our phones. Our phone numbers literally went across the country, but we also structured ourselves and created liaisons for critical patients. So I was the liaison for severe and critical patients, and my colleague, Dr. Umo, was the liaison for moderate and mild and asymptomatic patients. We then made contact with facilities, introduced ourselves, and started a good working relationship with the facilities. From our coordination aspect, often we didn't have a tier 1 response, which is what you would want in an ideal situation, a first aider. But as we moved forward as a country, we got VHTs involved. And in the rural areas, we started to use VHTs and ask them to go and do assessments while a more professional or tier 2 response team is sent. So on-scene care has a lot to do with managing the patient and other expectations around the patient, but also activating the formal EMS system. Where the country is going now, we are working on a regionalized EMS approach where each region will have a coordination call and dispatch center that manages patients or any activation either from the community or with facilities. Now, the other gap that we found is that ambulances from wherever they are being sent, were being sent with only one provider, a driver. We quickly started educating people that there are two things that go on in an ambulance. The first is driving someone to get a patient, vehicle, and contents from point A to point B. But more importantly, there has to be an emergency care provider on board. And as the pandemic evolved, we also then created levels of emergency care providers, from a basic emergency technician to an emergency physician at advanced level to do transfers of more severe and critical patients. And so at all times, at any time we had asymptomatic patients being moved, sometimes by bus load, as we were in the containment part of the response. And we slowly progressed to moving patients in ARDS, completely shocked, patients requiring fluids, vasopressors, on ventilation. And we created protocols that allowed for an emergency physician to be able to do the transfer rather than a basic providers. And gradually, we have found better response. And the beauty about it is that we created protocols, processes, including an ambulance patient care form, so that the team transporting a patient is forced to actually have better interaction with the patient beyond knowing that we are doing a transfer. And therefore, they are forced to clerk, they are forced to manage patients and to account for the time they spend with a patient during transfer. These are standard principles that exist in other countries, but they are things that we had not yet done before. And therefore, COVID provided us that opportunity. The other aspect of the continuum is a structured handover. We had cases, and my colleagues in Uganda and other African countries know that phenomenon of the dumped patient in a casualty or an emergency department. An ambulance shows up, they dump a patient and off they go. Nobody knows who the patient is, and they just, if you're lucky, have a few documents put on the patients just before the team goes. So what we required, and we also did educate the facilities, that the teams must do a structured handover. It required many of us doing evacuations, in addition to creating protocols, to actually go down with the team and do these case transfers and show them what a handover looks like, such that there is a handover of responsibility of clinical care and acceptance of the patient as they are presented during transition of care from the pre-hospital system to the hospital system, such that continuity of care is done well. Many times patients do deteriorate during care, and therefore it is important for things to be handed over, for the team taking over care, to look out for continue monitoring glucose. We gave insulin 5 minutes before we arrived at the facility, and so on and so forth. But in the facility, we also realized there were different aspects. So in the first wave, we had the non-traditional isolation facilities like Nambole, which was a strong part of the containment, part of the response, where we were taking positive people to avoid community spread. But we also had the Mulago, Naguru, and Entebbe in the Greater Kampala metropolitan, and in the regional referral hospitals each established a COVID treatment unit. Within any facility, there are different parts of the facility. There's the general ward, where you put patients who require less aggressive management, to the high dependency unit, and then to the intensive care unit. In our EMS protocols, we also established and adopted the triage processes that helped us identify patients who required intensive care unit. And we then established a relationship with the ICU team. Lucky for me, I had worked in that ICU as a medical officer, so it also helped. And we established a coordination mechanism where if a patient requires ICU, we have a conference call, discuss the case between the EMS, the referring facility, and the receiving facility, and have agreements on care and recommendations for adjustments in care as the intensivist saw fit, and also agreed on the best way to transport the patient. Sometimes we agreed that the transfer was unsafe. Sometimes we agreed it was timely to transfer, but sometimes we also agreed in delays in transfer. And simply because many times the ICU was full. And that brings me to the second wave. So the second wave was like an entire flip of the type of categories of cases we were getting. The ICUs, and this is from an EMS perspective. From my perspective, the ICUs were the first to get full when we hit the second wave. By the time we started admitting patients to HDUs and the ward, the ICUs were completely already overwhelmed. The Mulago team was already giving access block into the ICUs. We then went into the HDUs, and the facilities expanded rapidly to try to accommodate the severe and critical cases. And then we got access block, which therefore meant that severe and critical cases are being stranded in smaller facilities that are not routinely designed to manage patients of that severity. And what this meant for us was to quickly escalate and to try to support these facilities. So in Greater Kampala, we established a call center that is not just to facilitate transport, but we are increasingly receiving calls on guidance, both from families that are stranded with their loved ones that are getting worse, but also lower facilities seeking to transfer. And so what we are trying to finalize is to spread the gospel of recognize, resuscitate, and refer. So early recognition of patients who are unwell, who are acutely unwell, and quite severe or critical, because we found that with the hypoxic type of presentation in COVID, many times, and this is not just small facilities, but also people who are monitoring patients on home-based care, they have a pulse oximeter and they speak to their patient, but because the patient is still alert and speaking, they ignore the SATs of 85 and the fact that it is actually low and this patient needs to be supplemented. And so our call center is quickly evolving from coordinating our tier 2 response, which is our ambulance response, and supporting the tier 1, which is our first responders, but also to supporting with care provision, providing guidance on people on home-based care, answering questions such as, my father's SATs are now 82%, but he's fine, he's walking around the house, what do you think? And we are therefore quickly realizing the need to refer early. And this is one of the things we've struggled with. People are referring quite late in the process of the disease. And therefore, by the time they get to ICU, no matter what my magician friends, as I refer to them, do, nothing happens because we have missed a critical window within which our interventions would have improved this patient's outcome. And so the role of EMS and then the facilities and improving that initial early arrival of a patient, quickly resuscitating a patient to avert bad outcome is becoming very, very important. And some of the protocols that we have been pushed to escalate during, especially with the second wave and the high volumes of severe and critical patients, is triage as a concept, but also to drum it every day, and not just for COVID, but also for non-COVID patients. Everyone must be triaged. Anytime you walk into a facility, you should be triaged. And triage allows us to recognize those who need certain other levels of care. Those who triage as a priority one then go on to being managed in a resuscitation area. You don't need to have a full-fledged resuscitation room, but a resuscitation area where there's better care, and this will be determined. We're in a low resource setting, and this may look different for our different levels of care, but each facility needs to identify an area where the level of care there is higher than anywhere else in the emergency area, in the OPD, so you can stabilize these patients better. Priority 2 cases, of course, those in the middle.
Hello, Dr. Bruce.
I don't know whether
Hello. Sorry for interruption.
because as of now he's going through
Dr. Bruce, are you in?
Our BP.
Yes, I'm here, but I know we have to stop. Annette,
Okay.
can you summarize?
Okay,
Great,
doctor.
I'll
Thanks so
summarize.
much.
Following recognition, we have to go through the right approach to managing patients, a sequential approach that allows us to recognize and support the cardiorespiratory systems, especially stabilize a patient and then plan a patient disposition. That may mean admission to your facility and to the different level in a facility where care should be given. It may also mean discharging a patient if they don't require admission, and for COVID, elements of home-based care and appropriately counseling them. And finally, an appropriate and well-coordinated referral so that in the end, we have patients presenting to critical care if they need to, but that are well managed early on, and that allows for any interventions downstream to actually have meaningful outcome. Thank you very much. I will stop.